I think very good evening to all. I think yes, I will keep it short as it's something which probably is not very commonly seen nowadays. I think our anterior segment friends have done a great job converting all their phacos to topical anesthesia, and so we don't hardly find any kind of globe related perforation these days, unless it was very difficult for me also to search a video because it's been long that we don't get to see such things nowadays. And so anyways, I'll just speak about the basics of the globe perforation. So yeah, as I said, it is not very common nowadays because of the advanced techniques of phaco, femto, XYZ. I think I should not say XYZ because anterior segment people will mind about that. But well, we retina people, I mean, it's definitely we are safe from all these conflict to be handled. So, as retrobulbar and peribulbar local anesthesia, it gives an excellent akinesia and analgesia. But yes, it is associated with sight-threatening and life-threatening complications rarely. So let's see what the scope of complications occur. So very commonly we'll see when we give a block. So as we know that retrobulbar nowadays is not used. If in case we use it, we use peribulbar, and then we can have very commonly chemosis, which can be easily handled. Nothing to worry about that most of the cases. Then we have globe perforation, which may be because of the direct trauma. That is, patient may have pain, intraocular hemorrhage, and discomfort. Then we have the retrobulbar hemorrhage. Yes, very important to note as we have to halt the surgery in such cases. Again, a direct trauma to the artery or the vein, which may cause extensive ecchymosis, proptosis, pain, intraocular hemorrhage. So more often when we injure the artery, it is what it's lead to a compressive hematoma, and that is what is more important than a vein damage. Then we have optic nerve damage, that is a direct trauma to the vessels or the nerve again and can cause a visual loss. Coming to the scope of complications for systemic, in such cases, in blocks, we have oculocardiac reflex. A patient may have bradycardia, arrhythmia. It may be intraarterial injection, which may lead to cardiopulmonary arrest or convulsions, or maybe very rarely you may have an optic nerve sheath injection, which may lead to brainstem anesthesia. So, what are the patients who are at actually risk? So we, as anterior segment, we have to be careful in these particular patient lists that if the patient is at high axial length, yes, be careful, beware. More than 25 millimeter has almost 30 times higher risk than a normal patient. Posterior cephaloma, post scleral buccal surgeries, which may elongate the globe. That is another reason that we may have at risk patients, and then deep set eyes, severe enophthalmos, uncooperative patients, and very commonly but blocked by non-ophthalmologists, because we in a big, sometimes in a setup of camp or setup of a very huge camp patient or a huge setup of cataract surgeries, we may give blocks are given by non-ophthalmologists, which can create perforations. So what exactly happened? These are the basic roots of your peribulbar tract and where we give the block. But so the perforation can occur many a time at this particular site, where you can just probably enter the globe, and that is what is the penetration of the globe. Once this enters, the damage is restricted mostly to the retinal break, maybe a vitreous hemorrhage or a subretinal hemorrhage may be there. So now when we inject the drug, that is where another symptoms or signs starts appearing because of the globe. There is, when we inject the drug, it is sudden rise in the intraocular pressure, and obviously could lead to a CRAO or a corneal clouding or a pressure induced damage. So what exactly is the harmful? Lignocaine being not very unsafe, it is relatively safe, and it's shown reversal of ERG changes in some studies. However, what is the damaging is the hyaluronidase, which is mixed with lignocaine and is toxic to the retina. So if we are sure that we have anyways kind of entered, we should take an immediate step and operate and remove this content from the intraocular cavity. So what exactly how the perforations we'll deal into, it may be a single or a double perforation. Single, simple, that it just penetrates the globe, but however double perforations are more common. They are more missed because we don't get to see the signs. It just goes behind in the retrobulbar area, and then we just when we inject the drug, we might miss the same. So mostly repeated injections may be, there may be a history because we may not get analgesia, akinesia, and we tend to just supplement the drug, and we may tend to perforate it number of times. So well, keep calm. I think this complication can happen in the best of hands and the best of experienced anesthetists. So what we basically have to, because if there are high risk patients, we may, even as best of surgeons, we may damage, do a perforation. So what is the key is the early diagnosis and management, and we should avoid retinal toxicity, especially with hyaluronidase. So what are the signs for as a clinician? The most of the patients will have vitreous hemorrhage. Subretinal hemorrhage may be one of the very common findings again. Retinal breaks are seen, retinal detachment in the later stages can be seen. Proliferative vitreoretinopathy, if it is unnoticed, it goes unnoticed. There's a VH and we don't tend to do a B scan or something, we may miss that. Again, developing a proliferative vitreoretinopathy. Hypotony, many items we see on table when we give a block, we said, come on the table, we see hypotony. And retinal whitening and subconch hemorrhage very commonly can be seen also. So in scenario 1, we see that there is a soft eye on the table, and the media is sufficiently clear. We can do a surgery, but we should make sure that we do an indirect laser photocoagulation if the break is very posterior, and if it's an anterior, we can also try doing a cryo if the media allows. Obviously, if media doesn't allow us, then we obviously have to take it for the next day, and we have to postpone it. In scenario 2, if the patient develops a retrobulbar hemorrhage, just monitor the intraocular pressure, postpone the surgery for sure, and you just refer to your vitreoretinal friend, whoever, and this has to be dealt with because it's the damage to the artery, and it may lead to a compressive hematoma, which is the main problem. So this was one of the cases, like vitreous hemorrhage may have vitreous hemorrhage, hypotony or diminution of vision or hyphema. So just clear the hyphema first, do a vitrectomy, nice vitrectomy can be done. So this again, you can see the vitrectomy. So this was a subretinal hemorrhage, you can notice the subretinal hemorrhage in this case. So and there is a sub-ILM bleed also, so it's better to remove the ILM also in such cases by staining it with BBG. And then finally we can just probably laser the break areas and then put oil and close it. So that was the perforation side. Another case, again a vitreous hemorrhage. So there were multiple perforations in this particular case. Just want to show that there was basically an SICS which they have done a bridle also. So there was a perforation related to bridle as well as multiple perforation because of repeated injections. Just clearing the PRH over there, and then this was the first break. Then we had the second one, and it was, you can see it was how posterior it was. A third one next to the bridle injury also, and then I just lasered the whole thing and put oil and close it. So prognosis usually is good if we, as I said, if we take it early, because if we remove the toxic agent, I think it's the key factor. So one other case, it was a retinal detachment in this. It was actually detected later on, and then we could just do the vitrectomy nicely and then do a fluid exchange and put oil. Again, there was you can see that posteriorly there is all retinal bleed, and this was the break area, and we had to put oil in this case also. So as I said, yes, prognosis good prognosis is there in anterior break, single site perforations, and poor prognosis with RD, PVR changes, double perforation, and posterior breaks. So how to prevent these kind of happening perforations? Single injections only, as let's use a second injection as a supplement only, and only after failed first injection. Don't try to always give more injections always. Avoid needle insertions through supranasal site and infranasal approach, or an approach with next to the medial canthus may be preferred. Then limit the insertion to almost 25 millimeter, and you can use short beveled needles which give you good tactile sensation, so that even if you have kind of perforating, you'll know it much better. And well, in our cases, I use mostly this kind of block. I don't usually give any kind of peripulpar blocks in my retina cases. I just do a subtenon's epidural block, in which I take an infranasal quadrant, in which I just make a snip in the subtenon's area and then inject the block. It is very simple. We can just put topical anesthesia initially, and patient may not feel any complaint. It gives you a good, very good echinacea and analgesia.